Thank you very much for the nice introduction and for this invitation to present some data here. As you mentioned in the introduction, I'm working in Maastricht at Maastricht University Medical Center, but actually since a few months I also work for the German Diabetes Center in Düsseldorf, so I have part-time appointments in both positions. And I got this title talking about metabolic flexibility, and usually, of course, we look at metabolic flexibility as the change in substrate oxidation. If you compare the insulin stimulated state to the basal state, so the change in RQ, I would like to look at it in a little bit a broader sense. So, and if we also challenge the human body in another way, how well we can respond. So also some things that I will talk about exercise, how quickly we can respond to quick energy demand, for example, which I also think is a kind of metabolic flexibility. And actually, the method that I use is magnetic resonance imaging, and especially magnetic resonance spectroscopy. So instead of only getting anatomical information with an MRI scanner, we can also get some biochemical information looking at fat content and phosphorus metabolites, for example, in different tissues. And specifically, I would like to cover a few things. I would like to share some data on acetyl-carnitine, which we have recently worked on, and link to that also to carnitine supplementation, and then look at phosphorus metabolites at the beginning of exercise, and also present some data on not only hepatic fat, but also hepatic fat composition. So when we do proton magnetic resonance spectroscopy, it's the most common form of spectroscopy. And here you see the cross-sectional MRI image of the upper leg, and we place a volume of interest here. We can normally generate a spectrum like the above, where you can mainly see fat. And when you very closely look, there is a small peak, and this is actually acetyl-carnitine, but normally cannot be quantified. But if you change the acquisition protocol a bit, you can actually suppress the lipid either by T1 editing or by longer echo times, and make this acetyl-carnitine peak visible and quantifiable. So that's what we did. And we thought it's actually interesting to look at acetyl-carnitine because Debbie Muyo suggested that acetyl-carnitine can form as a buffer, can function as a buffer of acetyl-CoA. So if acetyl-CoA accumulates, it can be converted to acetyl-carnitine by the enzyme CRAT, carnitine acetyltransferase, and acetyl-carnitine can actually then leave the mitochondrium. And in that way, it prevents the inhibition of acetyl-CoA on PDH and on glycolysis. So in that way, it would be really important to be able to be well equipped to produce acetyl-carnitine in order to prevent this inhibition on glucose. And indeed, if this CRAT enzyme is knocked out in mice, you see that they become metabolically inflexible, insulin resistant. So here you see the delta RER between the basal and the insulin stimulated state, and you see that also in a glucose tolerant test, these animals get insulin resistant, glucose intolerant. And what we then in the first instance did, we measured this acetyl-carnitine just in the fasted state. Now, actually, in the afternoon, but after 4 hours of fasting, in 4 groups of subjects. So very healthy subjects, endurance-trained subjects, sedentary subjects, and those two were age and BMI matched. And then somewhat more metabolically challenged people, so obese subjects or type 2 diabetic patients. And there you see a really nice linear correlation between the acetyl-carnitine concentration that were measured and the insulin sensitivity as we determined it by clamped. In that case, it's the glucose infusion rate that is shown here. So the more insulin sensitive people are, the more acetyl-carnitine they generally have in their muscle. And what is also interesting is that if you have a lot of carnitine available, you're able to form a lot of acetylcarnitine, so it can be a limiting factor. And when we actually perform exercise, most of the carnitine becomes acetylated. So here you see a graph that the more intense exercise is performed, the higher the fraction of carnitine that is acetylated. So by performing, so we can look in the resting state how much acetylcarnitine is there, but we can also perform high intensity exercise and then immediately measure and then see what is the almost maximal capacity that you have to form acetylcarnitine. And these two things we investigated in 3 groups. So, and these groups were all age and BMI matched, but differed in glucose tolerance. And so we had a normal glucose tolerance group, an impaired glucose tolerance group, but non-diabetic, and then diabetic patients. And we compared the acetylcarnitine concentrations before exercise and then also after exercise. And in between these people, they performed a cycling exercise for 30 minutes at 70% maximal intensity. And here you see some characteristics. There were somewhat older and of course overweight or obese. No differences in body composition or physical fitness, but of course by definition the glucose tolerance was different. So when we then look at the acetylcarnitine concentration in the resting state, we do expect what we've seen before, like the normal glucose tolerant people have the most acetylcarnitine, but it's not significant. And when we look at what happens after exercise, we see that this becomes more clear. And here you also see the basal versus after exercise concentrations. So it seems that this protocol makes the investigation more sensitive. So we can conclude the capacity of skeletal muscle to form acetylcarnitine after exercise, as determined by magnetic resonance spectroscopy, seems to be blunted in impaired glucose tolerant subjects, and even more so in type 2 diabetic patients. And that we can better pick up differences when we look at exercise protocols. So, okay. And then a next step, and a logical next step would be, okay, if we now provide extra carnitine, does that increase metabolic health? And we actually did that in people with impaired glucose tolerance, and they increased metabolic flexibility, but they didn't improve in terms of insulin sensitivity as determined by clamp. But it was a short intervention period, and we wanted to see if we now make this intervention period longer and look in type 2 diabetic patients, do we then see this improvement in insulin sensitivity? So we investigated 32 patients with type 2 diabetes. They were not on insulin therapy, typical BMI and age for these patients. The study design was really simple in this case. We had a battery of test days and then 3 months of supplementation and the same measurements afterwards again. And in the measurements, we had these acetylcarnitine measurements by MRS and also a clamp. So just some characteristics. So BMI was overweight to obese, and by definition, of course, an increased fasting glucose. Just to show the compliance, or a mean of compliance here is when we look in plasma at the carnitine concentrations, we see that it's very quickly actually increased and very strongly increased in plasma. We also made sure that they adhere to the same lifestyles throughout the intervention, because we didn't want this to affect the outcomes. So there were no changes in body weight or activity patterns and so on. Again, we had this same protocol with the high intensity cycling at the beginning, at the end of the intervention. And what we then see is that all concentrations were lower at baseline, so the pre-exercise and the post-exercise concentrations. And after 3 months of carnitine supplementation, you see that acetylcarnitine in the basal state is already increased, but especially that these people are also able to form more acetylcarnitine after exercise. Then we performed a hyperinsulinemic euglycemic clamp with glucose tracer to also look at the liver. And when we then looked at the rate of disappearance, so at insulin sensitivity of the muscle, we see that this is clearly increased after these 3 months of carnitine supplementation. And quite interestingly, this seems to be mainly due to the non-oxidative glucose disposal. So this really seems to get a boost. When we look at substrate oxidation in the basal state and after 3 months, and also like at the two concentrations of, or through 2 infusion rates of insulin, low and high insulin, we actually don't see very strong differences of, before and after the carnitine supplementation. Some, like the carbohydrate oxidation, is slightly increased, and the lipid oxidation slightly decreased, but not always significant. So quite strikingly, in these diabetic patients, we don't see changes in metabolic flexibility, but we do see changes in the rate of disappearance of glucose and insulin sensitivity, but it mainly seems to be due to the non-oxidative glucose disposal. And also the insulin sensitivity of the liver, so the suppression of the endogenous glucose production by insulin was significantly increased. And there was a tendency for decreased liver fat after carnitine supplementation of 3 months. Also a tendency for improved glucose values. We also looked at a few more like general functional tests, sit-stand tests, quality of sleep, quality of memory, and there were also some improvements there, but this is really a bit tricky because there can also be a learning effect in these tests. So as we didn't have a placebo group in this group, I think we shouldn't value this too much. Okay, so but we can conclude that 3 months of carnitine supplementation increased the plasma pool of free carnitine, that's clear, and it also increased the pool of acetylcarnitine in the muscle before and especially after high intensity exercise. And we see a pronounced increase in peripheral insulin sensitivity, which was mainly due to a change in NOGD, and also hepatic insulin sensitivity was increased. And so this was really about acetylcarnitine, a metabolite that we couldn't detect earlier, and we can now investigate, and we can look at the beneficial effects of boosting this metabolite. We can also do magnetic resonance spectroscopy and looking at phosphorus metabolite in the muscle, which are of course also interesting, especially to look at during exercise and during after exercise. So here, again, you see a cross-sectional MRI image, and this is a typical phosphorus spectrum that you then get from this region. And to do exercise inside the MRI scanner, we use such a custom-built knee extension exercise so that we can, with this surface coil placed on the vastus lateralis, measure ATP, phosphorus metabolite in that muscle, where we can also take biopsies. And the nice thing with MRIs is that you can then have a dynamic measurement. For example, every 4 seconds you can determine such a spectrum and then look at the time course throughout exercise. And that has been applied for quite some time, and especially it was used and is still used to look at oxidative capacity. So here you see a typical time course of phosphocreatine. Normally in the resting state, that's stable, but as soon as you start exercising, it is decreasing. And if the intensity stays the same, it will reach a steady state. And when you stop exercising, it is rapidly resynthesized again. And this resynthesis of PCR has been shown to be almost exclusively aerobic. So it's a good window to look at mitochondrial function at oxidative capacity. But actually, it's also interesting not only to look after exercise, but also to look at the very start of exercise, what happens. So when suddenly the energy demand on the muscle increases, oh, that doesn't work. ATP demand increases, and actually mitochondria should be activated to produce this ATP. But this can actually be a quick process, or it can be a sluggish process. So there can actually be differences between people, and the underlying reasons for such a slow activation theoretically can be diverse. It can be due to oxygen delivery, mitochondrial inertia, slow PDH activation, or actually also slow acetyl-CoA delivery. So there can either be reasons within the mitochondria or more systemic reasons. And for this delivery of acetyl-CoA at the beginning, it's probably important to have large pools of acetylcarnitine, because that is a readily available pool of acetyl-CoA. You only need CRAT to convert it to acetyl-CoA and to metabolize it. So to study this, what happens at the beginning of exercise, we can do this phosphorus spectroscopy, measure such a time course, and look at the on kinetics. So what is the kinetics at the beginning of exercise, or at the off kinetics that is often done? So we hypothesized that this CRAT activity would be important in activating mitochondrial oxidation at the beginning of exercise. So we again had these 4 groups, and next to the clamp and the acetylcarnitine that we already discussed, we also performed this phosphorus magnetic resonance spectroscopy and looked at CRAT activity in biopsies together with Debbie Mouillot. And this is such a typical time course of phosphocreatine in time, which you see here. And when we are talking about the on kinetics, it just means that at the first part of this curve, we fit the mono-exponential curve and look at the half-time of this curve to say something about how rapidly actually the mitochondria kick in, so the oxidative metabolism kick in to spare phosphocreatine, because as soon as you get into a steady state, ATP demand is still the same, but it's not covered by hydrolysis of phosphocreatine anymore. So the better your mitochondria respond, the faster this on-kinetic will be. And this is actually explained here. So again, these 4 groups, the first 2 are age and BMI matched. And here you can see so we did actually see differences in these PCR on kinetics, so how quickly the mitochondria responded, and the most fit people had the shortest on kinetics. And on the other side, or inversely, the CRAT activity was highest in this group. And also the acetylcarnitine content was highest here, although here you see that there is quite some spread in the data. When you then correlate the CRAT activity with the half-time of the beginning of exercise, you also see this correlation. So it may well be that this speed of how quickly you respond to the ATP demands is dependent, at least partially, on CRAT activity. On the other hand, it could also be due to differences in ADP sensitivity, so how well do mitochondria sense the need of the metabolic stress by ADP concentrations. And there actually also we see that for the same relative intensity, the ADP levels were lowest in the trained subject and highest in the diabetic patients. And also here we see a correlation. So both these may be underlying reasons to inhibit or impair mitochondrial activation. I can skip this, I think. And there's one other thing that I would just shortly like to cover. When we look at fatty liver, of course, we know that this is related to insulin resistance, but we don't really know what the mechanism is and whether it's causal or not. And there is also quite some spread in the lipid content in that correlation with insulin resistance. And one reason could be that it's not only about the quantity of fat in the liver, but also about the quality. So what kind of fat is actually stored there. And when you look at fat molecules, of course, there are saturated groups and unsaturated, like double bonds and protons next to the double bonds. And these give different signals at different frequencies in the proton MR spectrum. And when you do this at high resolution, you can clearly see these separated peaks reflecting these different groups. And in vivo, it's a little bit more difficult because we have this overlapping peak. So the difficulty is to separate these two groups, for example. And we optimize this by optimizing the pre-processing, by optimizing the water suppression and the fitting routine. And when you actually invest into that, you can improve the quality and better separate these two peaks. And important here is also the knowledge that we use is that we know that this peak, a CH3 peak, is present once in every fatty acid, and the same is true for the alpha carboxyl group here. And so this peak here can be related to the CH3 peak, and by using this knowledge, we can actually separate these overlapping peaks. And by doing this, we can then calculate the amount of saturated fatty acids, monounsaturated and polyunsaturated fatty acids. And in the past, it was sometimes a saturation index was calculated, which just means the numbers of double bonds, but that then doesn't mean that you can differentiate between polyunsaturated and monounsaturated fatty acids. And we really wanted to make this distinction and also especially quantify the saturated fatty acids. And we validated this in oil phantoms with different content of PUFA, MUFA, and SFAs. And you see that there is a good agreement with which we actually know what's in there. We also looked at the reproducibility. And so these SFAs are interesting because they may originate from de novo lipogenesis. We know that de novo lipogenesis, the end product is saturated fatty acids, and this may actually be especially detrimental for insulin resistance. And we looked at this in a range of obese subjects with a very wide range of liver fat content, so ranging from only like below 1% to above to almost 40%. And we did this measurement with proton MRS, also looked at de novo lipogenesis with the deuterated water method and performed a two-step clamp. And if we then divide in like lean livers, a little bit fatty liver, and very pronounced fatty liver, we see that the content of SFA is different in these groups. And actually, when you then correlate, so if you look at the total fat content and correlate it to the rates of de novo lipogenesis in this relatively small group, we don't see a correlation. When we look at the SFA, at the saturated fatty acids, we actually do see this significant correlation, and the opposite with the MUVA content. Quite interestingly, also when we look at insulin sensitivity, we do see a bit of a correlation with total liver fat and the M value, and also with the SFA. When we specifically look at liver fat, at liver insulin sensitivity, so the suppression of endogenous glucose production, we actually see that it's not related in this population to the total fat content, but it is related. There's a negative correlation with the saturated fat fraction. So that's actually quite interesting to see that de novo lipogenesis is associated with a higher fraction of SFA in these people, and that actually also shows that different rates of de novo lipogenesis can modulate the liver fat composition. And on the other hand, that the measuring the hepatic SFA fraction can tell something about de novo lipogenesis. Okay, and we see that higher relative amounts of SFAs are associated with insulin resistance of the liver. These are the people who investigated this. So yeah, with this I would like to finish, and of course thank all the team, and thank you very much for your attention.